Inferiorly merges with the antero-inferior part of capsule and lower band of iliofemoral ligament. So this is the attachment of pubofemoral ligament. Next we go to ischiofemoral ligament. It is comparatively weak and covers the joint posteriorly. This is the ischiofemoral ligament. Fibers are twisted and extend from ischium posterior-inferior to the acetabulum and form the zona orbicularis and few fibers to the greater trochanter. Okay. So you can see how the fibers are twisted and the ligament is lying posterior to the hip joint and attached to the posterior-inferior to the acetabulum form zona orbicularis. Okay. And some fibers are attached over this greater trochanter. Next is ligament of head of the femur, also known as, this is very frequently asked in your viva, okay, where it is attached, ligament of the head of the femur, also known as round ligament of the femur or ligamentum teres femoris. All the three names are used. It is a flat triangular ligament. Apex is attached at the fovea capitis here. The apex is attached in this fovea capitis. The base is attached over the transverse acetabular ligament. Okay, base attached over the transverse ligament and the margins of the acetabular notch. This is very thin or even absent. It transmits the arteries to the head of the femur from the acetabular branches of the obturator and medial circumflex femoral arteries. Okay, this is the function, transmits the arteries. Next we go to acetabular labrum. What is acetabular labrum? It is a fibrocartilaginous ring. Okay, so this is acetabular labrum. The two ends of the labrum is connected by this transverse acetabular ligament inferiorly. Okay, so it is a fibrocartilaginous ring attached to the margins of the acetabulum. It narrows the mouth of the acetabulum, okay, which helps in holding the head of the femur in position. Okay, it narrows the mouth of the acetabulum. That is the main function. And within the acetabular fossa lies this fat pad. Okay, you can see yellow colored one. This is the fat pad. And this is the attachment of acetabular labrum here and here. Okay, understood? Next, transverse acetabular ligament of the acetabulum. A part of the labrum which bridges the acetabular notch here, this part of labrum, this is known as transverse acetabular ligament. A part of the labrum which bridges the acetabular notch, but it has no cartilage cells. And this notch thus converted into a foramen and transmits the vessels. And through this opening, the vessels are transmitted. Acetabular vessels and nerve to the joint, hip joint. Next, previous see here, this is the acetabular ligament vessels and nerves. They are entering through this opening and entering into the hip joint, supplying the joint. Next we go to the relations. Anterior relations are lateral fibers of pectineus and covered by femoral veins. Okay, here is the pectineus, this psoas major tendon, femoral vein, all these are lying anteriorly. Iliopsoas with femoral nerve separating the iliacus bursa from femoral artery and straight head of rectus femoris. Okay, here is the straight head of the rectus femoris. All these are lying anterior to the hip joint, covering the deep layer of iliotibial tract. Next, posterior relations. Posteriorly lies the quadratus femoris, covering the obturator externus and the ascending branch of medial circumflex femoral artery. Obturator internus with two gemelli. These are the three tendons. In between obturator internus and superior and inferior gemelli, superior and inferior to the obturator internus. And this is piriformis. Okay, so two gemelli separate the sciatic nerve from the nerve to quadratus femoris and piriformis. All these are lying posterior to the hip joint. Next, superiorly there lies the reflected head of the rectus femoris. Here is the reflected head of the rectus femoris covered by gluteus minimus, and inferiorly lies the lateral fibers of pectineus and obturator externus. Next we go to blood supply. Blood supply is important, okay. Those retinacular arteries are important. So it is supplied by obturator artery to circumflex femoral arteries, medial and lateral circumflex femoral arteries, to gluteal arteries, superior and inferior gluteal arteries. Okay. So medial and lateral circumflex arteries. Here lies the circumflex arteries. This is lateral femoral circumflex artery, and here is medial femoral circumflex artery. Okay, this they are forming a anastomotic chain around the neck of the femur. Medial and lateral circumflex femoral arteries form a arterial circle around the capsular attachment on the neck of the femur, and the retinacular arteries arise from this circle. So these thin arteries arising here, they are arising from this anastomotic circle, okay, and they are supplying the head and neck of the femur. And these retinacular arteries arise from this circle and supply the intracapsular part of neck and greater part of the head of the femur. A small part of the head near the fovea capitis is supplied by the acetabular branch of obturator and medial circumflex femoral artery here. This part near the fovea capitis is supplied by acetabular branch of obturator artery and medial circumflex femoral arteries. So this is the blood supply of the hip joint. Next, the anastomotic chain has been shown here. See here, this is lateral circumflex femoral artery. Here is the medial circumflex femoral artery. They are forming a anastomotic chain around the root of the neck. And from this anastomotic chain, these are the retinacular arteries supplying to head and intracapsular part of the neck. And near the fovea capitis, it is supplied by branch from obturator artery. Okay, understood? So you practice a schematic diagram like this for the retinacular arteries and all. Next, nerve supply. Hip joint is supplied by the femoral nerve through the nerve to rectus femoris, anterior division of obturator nerve, accessory obturator nerve, nerve to quadratus femoris, and the superior gluteal nerve. All these are supplying the hip joint. Okay, understood? Next we go to movement. What movements occur? Movements are very frequently comes in your long question. Okay, write down the movement. Ligaments very frequently comes, and these movements very frequently comes, and blood supply comes as explained why. Okay, why in fracture neck of femur there will be breaching of these retinacular arteries, loss of blood supply to the head and intracapsular part of neck, and avascular necrosis occurs. Okay, this part comes as explained why. Movements, what movements occurs? Flexion extension occurs around a transverse axis. Okay, so this will be the transverse axis. Flexion and extension occurs around this transverse axis. Adduction, abduction and adduction occurs in around a anteroposterior axis. And medial and lateral rotation, here will be the rotation occurs around a vertical axis. Okay, and circumduction is combination of all these movements, like the shoulder joints you have seen. Next, flexion is caused by psoas major and iliacus. Okay, strong flexures. Extension is done by gluteus maximus and hamstrings. Adduction is done by adductor longus, brevis and magnus. These are lying in the adductor compartment. Abduction is done by gluteus medius and minimus. Medial rotation is done by tensor fascia lata and the anterior fibers of gluteus medius and minimus. Lateral rotation is done by two obturators, two gemelli and quadratus femoris. Okay. Next, see here the direction of pulling of the muscles. This is the center of rotation. Okay. Here you can see two obturator, the piriformis, quadratus femoris and gluteus maximus. They are pulling in that side. Okay. So they are causing lateral rotation. And here these structures, gluteus minimus, medius, anterior fibers and tensor fascia lata, they are pulling from this direction. They are causing medial rotation. Okay. Next we go to the clinical aspects. Okay, so these movements, you practice a picture like this previous one for the movements, and muscle involved in the movements are very important. Next we go to the age pattern, interesting age pattern of different diseases of the hip joint. Generally occurs in this age group. So below 5 years there occurs congenital dislocation and tuberculosis of the hip joint. In 5 to 10 years Perthes disease occurs. 10 to 20 years coxa, vara, and above 40 years generally osteoarthritis of hip occurs. Okay. So next, তোর পাশের জন কি করছে রে তখন থেকে ঘুমাচ্ছে তো লোকে ঘুমাসনি রাত্রে Okay, so congenital dislocation, it is more common in the hip than any other joint of the body, and the head of the femur slips upward onto the gluteal surface. Okay, see here, this is the normal position of the head. Here it is dislocated upward, okay, in the gluteal surface. Head of the femur slips upward onto the gluteal surface of the ilium because the upper margin of acetabulum is developmentally deficient. That's why this dislocation occurs. And this causes lurching gait, and the Trendelenburg test is positive. Next, see here that this is Trendelenburg lurch. Abnormal spinal curvature occurs due to the dislocation of the hip. This is normal walking pattern, normal spinal alignment. Next we go to the tuberculosis of the hip joint. Osseous destruction and marrow edema involving the bones forming the hip articulation along with the synovial collection and reduced joint space. Okay, here the tuberculosis of hip occurs. The joint space, the black colored portion you cannot see here. There is reduced joint space and there is marrow edema. This bone marrow is showing edema. It is more black in color. And osseous destruction, it is less white than the normal side. See, this is normal side, it is less white because of this osseous destruction. Next we go to the Perthes disease or pseudocoxalgia. It is characterized by destruction and flattening of the head of the femur. Here, this is normal hip. Here, flattening of the head of the femur have been occurred with an increased joint space in X-ray pictures. Okay, this is normal joint space. Here, joint space has increased. Okay, here you can see this is normal head. This is flattened head of the femur and increased joint space. Next coxa, vara and coxa, valga. A condition in which neck shaft angle is reduced from the normal of the about 150 degree in a child and 127 degree in an adult. This is known as, this is normal, 120 to 135 degree in normal adult. Okay, if it the angle, this is neck shaft angle, this is long axis of the shaft, this is long axis of the neck. Okay, so the angle formed in between the neck axis and shaft axis, this is neck shaft angle, almost 130 degree. Range is 120 to 135. If it is less than 120, this is known as coxa vara. If more than 135, it is known as coxa valga. Okay. Coxa means hip joint, valga means there is reduced angle, vara means reduced angle, and valga means increased angle. Okay. And in child, normal neck shaft angle is 150 degree. Okay. So you have to calculate like this. If it is less than 150, then it is coxa vara, and more than 150 or 160, it will be coxa valga. Okay. In case of children, the range varies. Next, osteoarthritis of the hip joint. It is a disease of old age, and it is characterized by growth of osteophytes at the articular ends. See, opacities you can see, these are the growth of osteophytes over the articular surface, articular ends, and which make the movements limited. Grating movements or grating sound occurs during the movement because of the friction between these rough surfaces. Okay, surface becomes rough. Normally it is smooth surface and there is fluid. Here is fluid is reduced and the surface, because of growth of osteophytes, they become rough and grating sign will be produced. Movements are limited and painful. Okay, understood? This is features of osteoarthritis. Next we go to injuries of hip joint, fractures, definite edge pattern. So young age, green stick fractures of the neck occurs. Green stick means fracture line does not completely cross the surface. Okay, green stick, if you break a green twig, it does not break completely. Some part is attached. So in young child, so green stick fractures of the neck occur and displacement of head of femur. In adult, there is dislocation of hip joint. Old age, fracture of the neck of the femur is more common. Next, dislocation of hip is maybe posterior more common. Okay, and anterior is less common, central is rare. The sciatic nerve may be injured in posterior dislocation of the hip joint. Okay, because the fibers are loose and weak in the posterior aspect, posterior superior aspect. That's why posterior dislocation is more common. This is also important. Explain why question. Why dislocation of hip is more common on the posteriorly. Next, fracture neck femur. Okay, so we have discussed it yesterday, fracture neck. So these are the types: subcapital, cervical, basal. Damage to the retinacular artery causes avascular necrosis of head, and damage is maximum in subcapital and least in basal fracture. Are common in old age between 40 to 60 years. Fracture neck femur usually produced by trivial injuries like tripping over some minor obstruction. Patient falls down and cannot get up. Limb lies helplessly rolled out as if paralyzed, and X-rays confirm the diagnosis. Next, these are the fractures: subcapital, transcervical, basal neck fracture, intertrochanteric fracture, peritrochanteric fracture, subtrochanteric fracture. Next, so intertrochanteric between the trochanter, peritrochanteric along the trochanter, subtrochanteric below the trochanter, and these fractures occur in strong adult subject produced by severe violent injuries. That means the trochanteric fractures. But neck fracture is common in old patient, old and weak. Next, what will occur after fracture and dislocation? There will be shortening of the lower limb by fractures and dislocation and tuberculosis. These are the causes of shortening of lower limb, and the length of lower limb is measured from anterior superior iliac spine to the medial malleolus. Okay. Next, and sentence line. This is sentence line, and here is the Neelaton's line. These are disrupted, and this is Bryant's triangle. These are disrupted in case of fracture and dislocation of the hip joint. Okay, we have discussed sentence line. Next, disease of the hip like tuberculosis may cause referred pain in the knee. because of common nerve supply of these two joints. This is also important, explain why. In case of disease of hip joint, you will feel referred pain in the knee joint. Same root value of the nerves. Next, okay, that's all. So these are the clinical aspects. So I have discussed which comes as a question. Explain why. There are so many explain why question, and hip joint individually come as a long question. Ligaments you prepare, movements and muscle involved in movements, okay, and rates the blood supply important for explain why. You practice schematic diagrams, okay, understood.